Hello, my name is Professor Scarlett McNally, and this is a talk aimed at the public about exercise and the impact on health. Bearing in mind the public is a very wide group of people, so some of these slides have got too much information. There's graphs, there's ideas, there's tips, all sorts of different things. Just please let it float over. It's not intended to bamboozle you, and you can slow down and rewind anything that you're particularly interested in. So I'm an orthopaedic surgeon in East Sussex and honorary clinical professor at Brighton and Sussex Medical School. I have no conflicts of interest. The Centre for Pre-Operative Care pay my trust for half a day of my time, and I donate my payment for writing in the BMJ, the British Medical Journal, a column there, to the Medical Women's Federation. There are some other organisations I've been involved with, or I'm still involved with, that is on a voluntary basis, mainly about trying to get the public to take more exercise, swimming, that kind of thing. So for 10 years, I was on the Council of the Royal College of Surgeons of England. That's to do with education and how surgery should be done. And that was incredibly interesting. I've also done been involved with issues around diversity in surgery, trying to be part of the Women in Surgery network. They say there's me operating when I was pregnant. And we got a lot of resources about that in there. So I normally start public things with what's the most dangerous activity you can do. So there's an X-ray of someone with a dislocation of their finger joint, which is, it's a fairly simple maneuver to reduce them. And the answer to the question, lots of people say skiing or snowboarding or something, but I'll only accept two answers. And one of them is smoking, and the other one, the most dangerous activity you can do, is sitting down. Because most ill health is related to social deprivation or a sedentary lifestyle or smoking or combinations of that. Genetics is only responsible for about 20% of ill health. And obviously people can have bad luck, and these are just generalities. But the biggest predictor of ill health is social class. And so this is from the Marmot Review, which was collecting evidence about inequalities in health. And so on the x-axis, it's the least deprived postcode to the most deprived postcode. And these are the rates of ill health. So you're 2.5 times more likely to have heart disease or cancer if you're in the most deprived postcode compared with the least deprived. And it goes up little by little by little. So it's a dose-dependent curve. So this is a real effect. It's not just some random occurrence. And what actually causes ill health? You can think of the social causes, such as social class or poverty, difficulty parenting, pollution, or accidents, some of which might have been preventable. Or you can think of the physical cause. What is it that causes the body to react in that way? And that comes down to nutrition, smoking, physical inactivity, alcohol, and pollution. Those are the 5 big causes of ill health. So I was lead author for this document that came out from the Academy of Medical Royal Colleges in 2015. A real copy here. And this was from the Health Inequalities Forum. And it was about, we've identified, and they've identified it for decades, the difference in health in different groups of people. But exercise hadn't been identified before as something that could improve health. What could be done to make a difference, to make things better for some people. So that's where this document, that was why we wrote this document. And the Academy of Medical Royal Colleges has all specialties and general practice and public health involved. So the representation from multiple different specialties. And it was an honour to bring everything together for that. And just a little definition really about prevention. So primary prevention is never getting a disease. We'll call it disease X. Or you could say it's reducing your risk of X. So for example, 150 minutes of exercise per week reduces your chance of dementia by 30%. So it means you might never get dementia. Secondary prevention is things like screening. You catch something early, so they might have a simpler treatment than if it developed, for example, which isn't something we're talking about today. And then there's tertiary prevention, which is reducing complications of something when you have the condition. So if you have type 2 diabetes, but you do exercise, you will improve your health. You'll reduce your chance of kidney failure, problems with the eyes, that kind of thing, by a certain amount. Or you could call it part of the treatment for this condition. And exercise should be part of the treatment, part of the management plan for most long-term conditions. So here's some numbers that are from this report, and we collated all the evidence that was available at that time. So at that dose of 150 minutes a week, exercise reduces somebody's risk, that's primary prevention, reduces your risk of dementia, stroke, depression by about 30% each. So that's huge. That's more than most tablets do. In fact, reduces the risk of bowel cancer around 40%, breast cancer around 25%. So these are very big reductions in risk. The middle column is, does it treat these conditions? And yes, it absolutely does. Exercise helps. If you have cancer, it reduces the recurrence, chance of recurrence of cancer, that kind of thing, improves well-being, strength, so you're less likely to fall. And in the right-hand column is the lifetime risk in the UK of somebody getting one of these conditions. So these are very, very common. 15% of us will get dementia in our lifetime. 20% will have a stroke, that kind of thing. So these are common things that it is worth trying to prevent or trying to reduce the severity of. And it's not just me saying that. There have been a number of reports from Public Health England, as was, to try and encourage people to be more active to improve their health. So going back to those long-term conditions, at each age, the number of people with more long-term conditions goes up. So I've put the line there at age 65. We can all think of someone age 65. And at that age, over half the people in the UK are multi-morbid. They have more than 2 or more medical long-term conditions. And the problem is, it gets quite difficult to manage. If you've got one condition, often there are guidelines about how it should be managed. And it's, you have asthma, you do this and this and this, for example. But as soon as you have 2 or 3 or 4, suddenly you're on multiple medications. Some interact with each other. You feel you can't do very much because sometimes the management of one interferes with the management of another, if you see what I mean. So anything that brings down the severity or likelihood of any of these conditions is really, really worth doing. And from a surgeon's point of view, half the operations we do in the UK that require an anaesthetist are on people over the age of 65. So in this group that has multiple comorbidities. And they go up with age and they go up with social deprivation. But the good news is that people who do exercise reduce their risk very, very quickly. And the biggest benefit is people who do the least exercise now. So this is a graph about just increasing your activity. It's measured in MET hours per week, the metabolic equivalent of tasks per week, which is just a mixture of intensity and how much you do it. So I've put the red triangle as 150 minutes per week of moderate exercise. And you can see it reduces your risk very, very quickly from 1 to 0.8, as in it reduces by 20% your risk of whatever the disease is, to 80% of that risk rather than 100%, if that makes sense. So the biggest difference is just doing something, and then there are less gains over time. If you do a little bit more, it improves your risk up to about an hour a day, improvement of risk. And this is a different way of looking at it, because the risk curves are slightly different for different diseases. So this one has, for example, stroke. And again, we've got that arrow at 150 minutes a week of moderate exercise. So you improve your risk very, very quickly just for going for a walk, walking up and down stairs, doing that kind of thing, from 1 to 0.9, as in 90%, and then to 0.8 very, very quickly, just by doing something. It's a very steep curve at that point. And for other conditions like breast cancer, colon cancer, ischemic heart disease, it's slightly different with how much you do and how much it improves. But the biggest thing is just getting started. And this is from a paper by Moy et al. In the BMJ that they kindly allowed people to borrow their slide. And this is UK figures from something published in the Lancet about disability adjusted life years, the global burden of disease, and this is for the UK. And the top cause is tobacco smoking, so smoking is the top cause. And then we've got blood pressure, high body mass index, or obesity, and physical inactivity, alcohol, and then all the nutritional things coming after that as being the causes of ill health. And just to point out that 1/4 of adults do no exercise at all. So those people would benefit just a little bit from just a little bit of exercise. And this is on the movingmedicine.ac.uk website about if people can maintain their exercise, their strength and their balance through their adult life, then when they start to get older, they start from a higher point, and they're less likely to fall to a point where they require extra assistance. They've called it here the disability threshold. So as you go through life, people tend to do a little bit less, but we need to keep people being active as adults, so that they don't decline in their older years. But how do you do it? Has anyone ever decided to change something and it became too difficult? Any New Year's resolutions that you didn't quite manage to keep, for example? What is it that makes people realize they ought to do something, but then they do it? I put this example up about dog poo, because when I was a child, I normally, walking to school, there would always be dog poo. This is 1970s or something, a long time ago. I'm a lot older than I look. And people didn't think it was their job to pick up after their dog. It's, oh, well, it's in the verge, you know. It wasn't, people didn't think it was their job. So it came in with a kind of change of culture. But I think, so you see on this sign, there's a penalty if you don't do it. So that's quite an incentive. But if you look at how they're trying to do it there, it's a pooper scooper. And the problem with that is, what do you do with it? You've got a little plastic pooper scooper. And what do? Do you put it in your handbag? Do you put it in a plastic bag? Do you wash it with the laundry? Do you rub it off with a plastic bag and rinse it? It's kind of, there wasn't a proper mechanism. And I think if you're trying to change behavior, you need the practicalities. You need it to be completely simple. So what we do now is you have a plastic bag, you grab it, you turn it inside out, tie a knot, dangle, dangle. That's what everyone does, isn't it? And it's just normal now. But I think it wasn't that people didn't want to do it or they didn't know it was bad, you know, to leave dog poo lying around. It's just we hadn't quite got the practicalities right in the 1970s. And so if you're getting change, you need something that stimulates people to know it's important. So you need the numbers, the data. Some people need images or stories that hold in their mind about how important this is. But then you need the practicalities, and you need to normalize it. It needs to become part of culture. And I think we should change how the NHS works, because we've got something like 1.5 million employees in the NHS. And we should all think of ourselves and as role models for how things should be done. So we should have better cycle parking, cycle routes to hospitals. All the information leaflets should encourage exercise and good nutrition right at the top of this being important and valued. And for some people, you need the carrot, the encouragement, and some people need the stick, the fines if you don't do things, if you leave dog poo everywhere, for example. And change behaviour from a personal point of view, it's far easier to do something if you fit it into your schedule, if the right choice is the easy choice. So, for example, I cycle to work, but I wouldn't want to drive because there wouldn't be somewhere for me to park at the time I go. So it's just easier to go on my electric bike to work. People need knowledge. They need to know why it's important to change. But often a trigger gets people started. Some catastrophic news, a family member having a problem, something becomes that teachable moment. You need practical things. So I have waterproof trousers in my pannier when I'm cycling to work. So they just stay there, pair of old trousers, but waterproof trousers. And then if it's raining on the way home, I just pop them on. And it's just practical, it's just there, it's ready. And you need a backup plan for when you fail, just so you don't immediately go back to your old way of doing things. But we do need to see it as normal and change the attitudes and see what people do in other countries and see what is normal there. We definitely need infrastructure so that it's easy to make that easy choice, and that needs funding, and then regulations so that people know the better way of doing things are put into how institutions do things normally. Now I've put up the Moving Medicine logo up there, but also making every contact count, because any NHS employee can get this free training on how to talk to people, to patients about stopping smoking, doing exercise, eating well, looking after their mental health, that kind of thing. It's a really good training pack, not just for nurses, doctors and allied health professionals, but also for porters, receptionists, administrative staff. Anybody can do it in the NHS, and it's really powerful. It's a way of listening to when other people are talking about how they might change and supporting them in a way that might suit them. So I do encourage any of you to look for it on the eLearning for Health website, making every contact count. Because really, why do we do anything? So I'm an orthopedic surgeon. So this is a simple idea about the chemicals in your brain that make you feel better. So there's dopamine, which is stimulated if you reach your goal. So we need lots of mini rewards. If you've done something good, have a mini reward on the way. And then there's serotonin. So if you're included in a group, you're far more likely, you get that buzz of serotonin, you're far more likely also to carry on doing it if you sign up for a charity walk or run or cycle, because you're doing it for other people. And similarly, oxytocin is stimulated when you're doing a good deed. So we actually need to get teams to do things together and families to do things together, or doing something for a charity. We're far better at doing stuff for other people than we are for ourselves. And the fourth chemical is endorphins. So this is like your natural body heroin, but it takes 20 minutes to work, and you get it from exercise. But I encourage my patients, so for example, patients who've got a fracture in by the knuckle here, because they've punched a wall, because they were frustrated. After we sorted out the fracture, I kind of try and have a conversation with them about punching walls and damaging their hands, and can you just have your running shoes by the front door, just so you can go out for a walk or a run, or just get out. Just, you've got to get over that hump of not wanting to get out in order to be able to get that the chemical benefit later. So it's having the practicalities ready. And the problem is, we kind of think we do this oh yeah, you know, I go to five-a-side football once a week or something, people might think, but actually you need to fit it into that habit, but sometimes you don't realize you're not quite getting enough, or you're not prioritizing it enough, because your instant thinking brain is the kind of, oh well, it's raining, or I haven't done this, or I ought to do that, and you aren't putting your sensible brain isn't in putting your life in perspective, if you see what I mean. So we almost need to plan ahead. We need to plan for failure. We need to verbalize, tell people what we're going to do, have the practicalities ready, and ideally be in a team. And again, it's not just me saying this. The World Health Organization has produced reports on how to reduce ill health. And the biggest things, as we mentioned earlier, are diet and physical activity. So they've got a whole report that says we need to change the built environment, particularly active travel and space for recreation. So we need play parks for adults and for children. We need stairs to be labelled, and people running up and down stairs is a really good form of exercise. And then the multi-targeted things about walking and cycling to school and healthier commuting, just to try and fit it into people's normal daily life. So basically, it's 150 minutes a week of moderate exercise, and you need to choose what you do. So swimming is quite a nice thing to do, for example. It takes, you don't feel how much exercise you're getting, because you don't feel you're getting sweaty because you're in water, and it isn't jarring on your joints. So that's a really good thing to do. And in fact, I've been helping with the Health Commission at Swim England to put out fact sheets about swimming with all sorts of different health conditions. So basically, you choose what you want to do, and there's a finite number of options. So you might get a static bike or an electric cycle, which has power assisted, or a rowing machine, or you might go for walks, or walk up and down stairs, or take up a sport, or do something with other people. So it actually needs to be something you think about doing and adding in. And the chief medical officers for the United Kingdom produced some guidance for all adults. And I've put up the infographic here for disabled adults, because they also need to get 150 minutes per week of moderate intensity exercise, and also strength and balance training. Chief medical officers acknowledge that some people are quite frail, particularly frail older adults, but even in that case, we should reduce the amount of time people are spending sitting, try and do sit to stand exercises. That's really good for strengthening around your hips. Little short walks, climbing stairs, that kind of thing, to try and reduce the number of people with frailty who have a very high chance of having, say, a hip fracture. This is my top tip, parkrun.org.uk. They now also do park walk. So you don't have to get fit in order to turn up. You just turn up. So it's 9 o'clock on Saturday morning. There are hundreds of places around the country. In Eastbourne, there's one in Shinewater Park. If you go on parkrun.org.uk to find it first, you can get a barcode, and then they log your time and send you an email. And it's lovely to do things together with other people. And this is, so it's that's a 5 kilometre walk or run or jog, and you see all sorts of different people there, and you get that buzz from doing it. And I really, really recommend it. And as the British Medical Association put it, the best forms of exercise are those that fit into everyday life. And electric cycles have got massively better over the last few years. So these are two research things I've quoted here, that people who, if you give a group of people, some an electric cycle and some an ordinary cycle, their physical activity levels are just as good, their fitness is just as good, because the people with electric cycles use them for longer trips and use them instead of their car. And these are two of my electric cycles there, and you can see you plug it in like you charge up your phone once a week, plug in the battery, and I now use my electric cycle for shopping trips and going to and from work and things that I might have otherwise driven. And the other paper there is that workplaces that loan employees electric cycles can't get them back because their employees just like them so much. And Some people will still need a car, some people will need a mobility scooter, and these do maintain people's independence. But just be wary that they increase sedentary time. So there needs to be some way of fitting back in some exercise into other parts of people's weekly activities. Cycling to work reduces your risk of heart disease by 46%, halves the chance of dying from heart disease, reduces cancer incidence by 45% and cancer mortality by 40%. That was an article in the BMJ. And so the advantage of cycling to work is it's so fitted into your schedule, that's just what you do. Just a point about parking. If parking is freely and generously available, it quadruples the chance of people driving a car to work. So we actually need some disincentives to people driving. Going back to active travel, people can worry about the risks such as pollution or collisions, but the benefits to health outweigh the risks by 10 to 1. Now about pollution. I was previously on the UK Health Alliance for Climate Change, which has some very interesting resources. And again, that's representatives from multiple royal colleges and other institutions. And this is a report from the Chief Medical Officer in England from 2022 about air pollution. And air pollution is really in two sorts. There's toxins or chemicals, and then there's particulates, little fine bits of matter. And the Royal College of Physicians and Royal College of Paediatrics and Child Health also produced a report about air pollution. And they talked about that fine particulate pollution as being quite damaging. And the risks are not just to the lungs, but the problems with inflammation and metabolism, so that people have a higher chance of type 2 diabetes, poor cognition, that means dementia, heart attacks, strokes, heart failure, and lung cancer from high pollution. And they've recommended people to try alternatives to car travel, such as active options or taking the bus or the train, walking or cycling. Now, particulate pollution, bearing in mind that transport's now the main source of air pollution, but half of it is the particulates, and that's brake and tyre wear and road abrasion. And electric cars still have that because it's based on the weight of the vehicle rather than what's coming out of the exhaust pipe. And the problem with the small particulates is they get through the body's defenses. They can go between cells, in fact, to get in, and then they cause that inflammatory reaction directly, which is probably why pollution has that effect on increased chance of cancer. Again, this is from the Chief Medical Officer's report of the distances travelled by bicycle, and you can see using a car has only been temporary. It's only since the 1950s that people have driven. Before that, far many more kilometres were ridden by bicycle. And this is quite interesting, this graph, because the different distances are quite interesting. Bearing in mind Eastbourne is 5 miles across. Under 1 mile, most journeys are done walking, 80% done walking. Between 1 and 5 miles, suddenly the amount of walking drops off, probably because it takes quite a long time if you're doing that as part of your journey. And sadly, most of those journeys are done by car, but it's an easily cyclable distance. What you need is buses or cycles or electric cycles in order for people to make that switch from a car. And then over 5, it becomes more again, far more car journeys. And this is about car crashes. So East Sussex has a bad reputation for too many people killed or injured in road crashes. And it's particularly a child pedestrians at start or finish of the school day. That's a problem because children's eyes aren't really developed enough to judge speeds, and there's often high speed traffic in those areas. Often in the more deprived wards have far greater incidence of child injuries. So what we need to do is put in 20-mile-an-hour limits, have safe travel around schools, and also educate drivers to slow down, particularly to give more space. And ideally, fewer cars on the roads would make it safer for everyone else. And that's indeed been shown in Edinburgh when they introduced 20-mile-an-hour areas for all the built-up areas. They reduced road traffic collisions by 40%, 40%. A bit about the NHS. So this is again from the this is from the King's Fund about inequalities in health. So you've got the deprivation index along the bottom. So people in the most deprived area become ill, that's the bottom line, much younger than people in the least deprived area, and they die earlier, that's the top line in orange, than people in the least deprived. But if you look at the red arrows, the people in the most deprived areas on the left there live about they have twice as many years living with ill health as people in the least deprived areas. So that's what the NHS has to look after, the people who have ill health, particularly over many years. And so if we could improve the health of people in more deprived areas to that least deprived areas, we wouldn't need to supply so much healthcare, if you see what I mean. I know that sounds callous, but it's a different way of looking at it and makes everybody feel involved. And I've done some work with the Centre for Pre-Operative Care about how we can reduce complications for surgery, because complications are quite common. 10 to 15% of operations will have a complication, and they're 5 times more likely if people are frail and 4 times more likely if someone is physically inactive. But we can about halve complications with daily exercise, and we need to encourage people to do this and reduce the number of cancellations of surgery as well. If we can get people to be so fit they can go out the same day or the next day rather than having to require a bed in the hospital afterwards. So if they can strengthen their legs so they can get to the toilet themselves, they aren't needing their arms to be strong to get out and mobilize. And some really good works come out of Macmillan, the cancer charity, trying to encourage people to do physical activity during their cancer treatment because it helps people manage, it helps them recover their physical function, it reduces their chance of the cancer coming back after the treatment. It's a small reduction in risk, but it is worth trying. And it helps maintain people's independence and well-being. So they've done some work around prehabilitation, that's getting fit before chemotherapy or before an operation. So it's about exercise and some discussion about how to reduce alcohol and smoking and improve people's nutrition, such as eating fruit and vegetables to help wounds heal and that kind of thing. But there's now more targeted support for people, but it's very patchy around the country, but it's really, really worth having because it about halves complications, a package like this. It's a really good website, movingmedicine.ac.uk, and that it's got pages for the public, but it's also got pages for healthcare professionals about how to fit talking about doing more exercise into a 1-minute consultation. It doesn't need to take very long. Some of it is just about sowing the seed with the patient and then following their idea about what they think they might do and agreeing with them about whether that's might be a good idea to try. Just to point out that even if people have got lots of different conditions, it is safer for them to do exercise than to be sedentary. And people think it's risky, but the risks are actually very, very low indeed. So everybody should be doing something. But people start from where they're at, and just doing a little bit, as we said before, makes a massive difference. And this perioperative care is from the moment surgery is contemplated until full recovery. So we can think of all these stages. And what we're trying to do is to get the exercises you might have afterwards introduced beforehand, so people aren't waiting in hospital to see the physiotherapist, for example, and trying to get people as fit as they can be from the moment an operation is considered, so they aren't cancelled on the day or near the surgery because they're not fit enough, or other things that people might not have considered causing the operation not to go as well as it might. And the Centre for Pre-Operative Care is a partnership between some very high profile organisations and is largely funded by the Royal College of Anaesthetists, with patient groups and charities and other organisations involved. And I'm deputy director there, and there's some fantastic work on cpoc.org.uk. Because we know things go wrong with healthcare, and there's differences, unwanted variation, they call it, around the country, with different places having different results. And some of that could be improvable with some very simple measures, particularly getting the patients on board and to be as healthy as they can be, rather than just assuming that the complications are inevitable. And we collected evidence at the Centre for Pre-Operative Care about if there is this kind of approach and that preparation for surgery, it reduces complications by half, reduces bed stay by 1 or 2 days. It's better for the teams working together and better for patient satisfaction. And I've done some work on preoperative assessment and optimisation. And again, it's a similar thing. It should be, the waiting list should be a preparation list. People just need to find what they can do and then do it. And there's 7 things that reduce complications of surgery. Stopping smoking, doing some exercise, good nutrition, that's fruit, vegetables, protein, a medication review and a review by a senior doctor or nurse, moderating alcohol and drug intake, and something about psychological preparation, then physical preparedness, so that people are practically ready for things, which is quite empowering to feel ready. But we're mainly talking about exercise here, and the benefits aren't just the heart and lung fitness. It has an effect on inflammation and a metabolic effect. That's how your body processes sugar. And it's very empowering, and it's good for pain management, which reduces the person's need for opiates after surgery. So we've got resources on the cpoc.org.uk/patients website, Fitter, Better, Sooner, using that teachable moment. And the other thing that's some quite recent studies have shown that with older people who've been recommended for an operation, people who see a geriatric service and talk through their operation and what they could do to be as good as they could be, 14% decide against the surgery, because in some cases it's something you might die with, not of. And sometimes talking about would they manage if they had a complication, or would it be destabilizing just the normal way of getting through the surgery, is too much for some people, particularly since so many people are living to very old ages, and sometimes it's quite a delicate balance of their independence. So we do need to have these conversations, but they need to be individualized to the patient, with some very senior clinicians having a discussion. But again, you can see 50% of people have their lifestyle advice, or 75% have medications changed. It's anything we can do to get people fitter for surgery, because people who have complications have the most difficulties and actually use the most resources in the healthcare system. I've just put this about me. I was very ill in 2018. I've got myeloma, which is cancer of the plasma cells in the bone marrow. And so I needed quite a lot of chemotherapy. The abnormal cells made abnormal antibodies, which then stuck on my heart and stopped that moving properly. So I couldn't walk up a flight of stairs. I couldn't walk. And that's why even I, who'd written stuff about exercise in the past, was a bit scared. And my doctors encouraged me to go for a walk. I got an electric cycle because I couldn't cycle on an ordinary bike. and I built up my fitness. I was told I would never be fit enough for a stem cell transplant, but I managed to increase my fitness and have a stem cell transplant, and that went well. And then for various reasons I needed a hip replacement, but I'm back at work, which is lovely, half time. So it just needs to be fitted in and part of the treatment program. This is just me going down for my hip replacement. And I got one of these static bikes to use afterwards, because I knew I couldn't be out on the roads immediately afterwards. It was just to keep things moving, because every little helps. And it has other benefits. If we can reduce the number of operations we're doing and reduce the number of unnecessary complications, we aren't wasting all those bits of plastic and time and heat and everything, keeping somebody in an intensive care bed when they might not have needed it, all those sort of things. It's that sustainability to reduce, reuse, recycle. But if we reduce, that's the cheapest of all. Something about money. 70% of NHS spending is on these long-term conditions we talked about. And bear in mind, 25% of the population do no exercise at all, and 47% of older people do no exercise at all. If we could just improve a little bit, we would save NHS spending. And this is a graph. The little grey dots represent 1 out of 100 patients. So 3% of patients, these are hospital costs, 3% of patients are responsible for 45% of the costs of hospital. So these are mostly people who've needed repeated stays in intensive care, further operations, things have gone wrong, infections, that kind of thing. So it really is worth trying to address poor health for everybody, but probably particularly for people whose health is the worst, rather than the easy win of trying to get people that are a little bit active doing a little bit more. But we should be doing that as well. I wrote a paper with some others about if we could get middle-aged and older people to do a bit more exercise or physical activity, we wouldn't need so much social care, because the need for social care is based on how much people can do. Can they get to the toilet themselves, or do they need someone to help them? That kind of thing. But if older people start exercising, they can regain some fitness to the level of a person 10 years younger. So that's drop a decade. And we need to turn this round. We need to get people to realize this is normal, because aging is different from lack of fitness. So we could think, why do we need to change to support other people to do some exercise? And you could say it's nice for them, it improves their mental health, physical health, well-being. Or you could say, as a society, we absolutely can't afford not to. People being more active saves NHS costs, saves social care costs, and we're each predicted to need 10 years of social care in the future. We have we know families where one person has reduced how much they work in order to look after someone else. There are many unpaid carers in the UK. And that should be half the East Sussex social care revenue budget is spent on adult social care. So if you reduce any of this, then there'd be more money to do other things with. And also, it would be nice to have more disposable income. So many families could manage with 1 car per household if the school run could be done on, say, bikes or scooters or walking. And we just need to change the mindset. And now I want to mention bespokecyclegroup.org.uk in Eastbourne. So I was chair of this for a few years, but sadly we're limited because of the lack of funding. So Eastbourne's only 5 miles across. The pink is where there are cycle routes. And sadly, the green and everywhere else is where there ought to be, but that aren't. And cyclists are really being pushed onto the ring road. And what we actually need is safe routes from the shops to people's homes, to schools, to leisure activities, as they do in European countries. Otherwise, people will continue to drive. We also need a good bus network, because these journeys are easy to make by bus. So what we need are safe routes where people are going, and safer drivers' behaviour, which basically means gives cyclists more time and more space. This is about pedestrian casualties. There have been 142 pedestrian casualties from being hit by a car in 5 years in Eastbourne. So if more people were on cycles or on the bus, there would be fewer collisions. And it's 142 people too many. We just need to acknowledge that this is a public health problem too. And the problem is there are some initiatives that are trying to change things but going in the wrong direction. So this is the East Sussex County Council plan from going from Eastbourne Station to the sea, and they want to ban cycling from all of it and have it fully pedestrianised. But the problem is at the moment, that bit right in the middle, the pink bit, for example, outside Marks and Spencer's, you can drive with a car. So they're going to ban driving, which is good. But they should make it into a two-way cycle route so that people can get across from one side of town to the other. Otherwise, people on cycles are pushed onto the busier ring road. And what we need to do is think about potential cyclists, particularly now there are electric bikes that are much easier to get out on, rather than the people who are cycling now. And we need to improve the seafront. That the part where the promenade is narrow, we could put in a two-way cycle route instead of parked cars, just along that by the sea defence wall. The explanation's all on the bespokecyclegroup.org website, but there are plenty of other places to park cars. But taking out parking always feels controversial, but other places that have done it have not looked back. And we need routes for people to get from Langley, from Sovereign Harbour into Eastbourne, rather than just reflex driving the car. And sadly, there are some consultations where, for example, it's almost set up in advance. So this one about the town centre says, for example, pedestrianising Terminus Road may create severance issues for cyclists who may in turn oppose the scheme. So right at the beginning of the work, they are trying to stop cycling and trying to see that as a key risk that cyclists will object, rather than thinking that most people could cycle for simple journeys, and this isn't just a them or us problem. In fact, we're all on the same team. 21% of UK adults have a disability, and actually many find it easier to cycle, particularly an electric cycle, than to drive. Congestion's going up, nobody wants that. Cars take up quite a lot of space, and parking's restricted. So we need more buses, more walking, parking restrictions perhaps, and people seeing cycling and electric cycles as a way of other people getting that modal shift from a car. It's quite a lot of data. 57% of UK adults say cycling is too dangerous. 34% of children are driven to school. 69% of car journeys are under 5 miles, which is easily cyclable, but only 3.5% of walking journeys are over 2 miles. So we really do need the buses and the cycling to get those journeys converted from cars. But there are many different types of cyclists or potential cyclists, and at every age, only half as many women cycle as men for multiple reasons, and women are more likely to trip change, to go from school to shops and so forth. I've got a column in the British Medical Journal. I just wanted to quote somewhere from Eastbourne saying, when local residents petition for a zebra crossing by their school, their project joins the list of at least 79 others, and the funding goes only to the top lucky 3 projects. This is what it's like in Eastbourne. The funding decisions need to be different. The priorities need to be different. If you put in a crossing, then children are far more likely to walk to school. Otherwise, there might be 1 or 2 points that make parents not want their children to walk, and then you're in a vicious cycle of people driving. I've got more papers on scarlettmcnally.co.uk. Please do look at those. So what can you do today? I just wanted to highlight the new highway code. It encourages you to leave 1.5 meters, that's 5 feet, when overtaking people cycling. So that's I'm 5.5 inches, so it's quite a lot of space, isn't it? But the critical thing is do not overtake if it's unsafe or you can't meet that distance. And that's where people go wrong. They try and overtake, and then they give a nice bit of room to the other lane, but actually they're then in the incoming traffic. They don't think, actually, now I'll just slow. You might feel you're like a muppet just driving really slowly but behind a cycle, but you might be the one person that's giving that person a bit of space, so they make that journey again and again and again, and they don't just have a near miss and get back in their car. Or I sit in fracture clinic and see people with who've been knocked off their bike from just fairly small injury that are just scared to go back again. So we need to give that 1.5 meters. And also people cycling are encouraged to ride in the center of their lane, particularly at the approach to junctions. So this is my last slide. Just thank you so much for your attention. Follow me on Twitter at Scarlett McNally. Just remember, active travel is a best buy for health. It reduces pollution, congestion, and collisions. Just that 150 minutes a week of exercise reduces your risk of dementia, diabetes, stroke, falls by at least 30%. We need modal shift to get people from a car to a cycle, electric cycle, walking, or a bus. Think of the people freeing up the space. 69% of car journeys are under 5 miles, which is easily cyclable. Electric bikes are a game changer. But simply, we can't afford not to. We need people to be healthier, and people at the moment are so unfit. Their health is getting worse. So thank you very much for your attention. It's been a pleasure to talk to you.